You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 11th, 2019. This week, appropriate use for cardiac imaging, heart failure readmissions again, marijuana use, X-ray exposure, and hormone replacement therapy. First up is that multiple cardiac societies have come together and released an appropriate use criteria for imaging test for non-valvular heart disease. This is a surprisingly brief 23-page document that is mostly in table form. The authors take 100 clinical scenarios and they rate the appropriate use criteria of each test, and the range is from rarely appropriate, which is numbers 1 through 3, maybe appropriate, numbers 4 through 6, and appropriate, numbers 7 through 9. Now here's some comments on this document. First, let's just recognize the elephant in the room, and that is that imaging of the heart is the pani agua of cardiology, the bread and water. Echo and nuclears bring riches to cardiologists, and in this new world where our value to our employers is based on our RVUs, ordering and reading these well-reimbursed imaging tests is paramount. So encompassing the 100 common scenarios, the authors have only 45 references in this document, and many of these references are consensus studies and consensus documents, not real trials. That tells me that the bulk of imaging is an evidence-free zone. The appropriate use criteria have had a role in getting paid and being rated on quality. For instance, the AUC for PCI has surely been causal in the epidemic of unstable angina. That's because for PCI to be appropriate for stable coronary disease, the patient must fulfill many criteria. But for PCI to be appropriate for unstable angina, it's quite easy. It's almost always appropriate. So boom, people just say this patient's chest pain is accelerating or at rest or new, and in goes the stent. Well, I looked at this new document, and it has scenarios that are sufficiently general, and the 1 to 9 scale is sufficiently broad to basically one can rubber stamp the continued overuse of cardiac imaging. And I'm sorry to sound cynical, but I don't see this document as helping at all with the massive overuse of cardiac imaging. For instance, one of my pet peeves is the overuse of nuclear imaging in patients with atrial fibrillation. I see it every day. A person is totally fine. They come in with AFib, but beforehand they've had no symptoms. Then they get atrial fibrillation and they feel symptoms, chest pressure, shortness of breath, etc. Now they can come in, and if they see a certain group of docs, they get on what I call the train. An echo is done when the heart is going 150 beats per minute, so now they have LV dysfunction. Then comes the nuclear stress test to evaluate for quote unquote ischemia, which often leads to a cath, and then we find incidental coronary artery disease, then the PCI, and still the atrial fibrillation is yet to be addressed. In one fell swoop, one episode of AFib, the patient can find himself dependent on a cardiologist maybe for life. So what does the AUC say about nuclears for atrial fibrillation? Well, it may be appropriate, and it's given a 4. So what does that really mean? That means a doc has carte blanche and can order any kind of nuclear stress tests for atrial fibrillation. Here's another pet peeve on echocardiogram. The AUC document deals with palpitations without symptoms or signs of heart disease, aka that means no angina, no heart failure, and a normal exam. So what does an echo in this scenario get rated? As a maybe appropriate 6. Again, carte blanche to order an echo, which these days in high deductible health plans may cost a patient $1,000 or more. It's the same thing with routine high blood pressure with no symptoms and a normal exam. An echocardiogram image is rated as a 5. So boom, carte blanche. Now, last comment before I stop. I can't wait for point-of-care ultrasound to become mainstream. Then instead of exposing patients to $1,000 echocardiograms, we can examine the heart with our eyes right at the bedside. Now, while some will say that this may lead to more testing as docs learn the new skill, for me and some of my colleagues in the cardiology office, we would probably drastically reduce the number of echocardiograms we order if we could just look at the heart with a point-of-care ultrasound. The next topic is readmissions again. Now, in the last couple of episodes of this podcast, I've discussed the Heart Failure Readmission Reduction Program, the HRRP. Well, this week, economists now, publishing in the journal Health Affairs, have dealt another blow to the policy of punishing hospitals for having higher rates of readmissions. Last week, we discussed the Beth Israel paper, which found that the HRRP, the readmissions penalty, may be associated with higher rates of mortality for heart failure and pneumonia, but not MI. Now, consider that the safety side of the HRRP as an intervention. This week, The Economist and Health Affairs, they addressed the efficacy side. For example, did the HRRP, the Heart Failure Readmissions Program, actually lead to the reduction of readmissions? And provocatively, they found in their analysis that no, it did not. Now, this paper is pretty cool and revealing. It's a different kind of paper, and I'd recommend going and look at the actual methods. But here's what they found. That in January of 2011, during the anticipation period of the HRRP, the CMS, or Medicare, changed the electronic transaction standards used by hospitals to submit Medicare claims. And this change allowed hospitals to provide an increased number of diagnostic codes. So in the paper, their figure 1 shows that in the course of a month, 1 month, the risk-adjusted rate of readmissions drops by nearly half. And this probably explains why coders in my hospital chase me around trying to get as many diagnostic codes on our patients as possible. Now, this change in coding happened by coincidence. The HRRP was implemented just before this change in electronic transfer standards, and thus the authors believe this has created an illusion of lower readmission rates after the HRRP. So the increase in diagnoses per claim stems from fewer claims having 9 or 10 diagnostic codes, and more of these claims having 11 or more diagnostic codes. And the authors say clearly that this doesn't represent gaming or upcoding. It's just that before January 2011, they could only submit 10 codes. And after 2011, January, they could submit many more. But that wasn't all that the authors did. They did a second analysis in this paper, and that adjusted for differences in pre-HRRP readmission rates across different samples. And they found that the declines for targeted conditions like heart failure and pneumonia that occurred at general acute care hospitals were statistically indistinguishable from declines in 2 control samples. And so there's 2 possible scenarios that can be concluded here. It's either that the HRRP had no effect on readmissions, or it led to a system-wide reduction in readmissions, that is, a reduction not limited to the target conditions, and that was roughly half as big as previous estimates. Distinguishing between these 2 possible scenarios, they said, would be a good topic for future research. The authors have a great final sentences, and I have little to add to that, and they write that if the HRRP has limited efficacy, the rationale for the program's existence becomes even weaker. Now, why? Why is that? Because pay-for-performance programs have 2 potential serious downsides. One is that these programs can cause gaming, which can then have negative consequences, such as preventing patients from receiving needed care. And the second downside is that pay-for-performance can expose patients to the risk of unstable funding, especially of safety net hospitals. So in general, if pay-for-performance programs are to be successful, they must have benefits greater than these 2 downsides, and it's not clear that the HRRP program has that. Third topic is about marijuana. Now, marijuana made news this week, big news. The Annals of Internal Medicine featured numerous short pieces on the drug. Malcolm Gladwell took on the tough topic in the New Yorker. Now, here's some of the things I learned about marijuana this week. Mainly, I was shocked how surprisingly little we know about this drug. Due to its illegality, we don't even know the basic pharmacokinetics of the drug, like the dose-response curve or elimination. We also have limited data on efficacy or safety, and some of the studies on pain and nausea relief are far from compelling. For instance, THC drug concentrations have increased in recent years. Basically, the pot of my era was a lot weaker than the pot used today. I also did not know of the observational studies suggesting a link between high use of marijuana and schizophrenia. That's bothersome, though we can't make causal links here. Now, Gladwell's piece was especially effective as he compared the extremely strict approach to e-cigarettes with the extremely lax approach to marijuana. And after reading Dr. Will Boggs' story on the Heart.org Medscape Cardiology and the Annals pieces and Gladwell, I came away with a much more guarded view of this drug, especially given the increased doses and increased usage that's been brought by the decriminalization process. This marijuana issue has the potential to bite us in the butt in coming years. I wonder what future generations will learn about this topic. The next thing I'm going to talk about is X-ray exposure. First, let me say that I commute to work on my bike and I don't wear a helmet. And I don't worry about getting heart disease. Why? Because I've stood side by side with X-ray machines for 2 decades. Many years ago, I once did an entire CRT and forgot to wear my lead. So risk-wise, I figure that my occupational exposure is what will finally take me out. And findings from a simple but elegant study published in Circ Intervention should give interventional cardiologists pause about this whole X-ray exposure issue. These authors, using radiation data from about 1,100 coronary angiogram procedures that were done between 2005 and 2016, this group set out to study the association of BMI, body mass index, and physician radiation dose during the procedure. There were 4 main findings. First, half the group of these patients was obese, and about 10% were morbidly obese. Now, this was in Michigan, which is not known to be one of the most obese states in the U.S., but still, those are sobering statistics. And second main finding, a significant increase in physician radiation dose was observed across patient BMI categories. So a patient BMI greater than 40, which is super common in Kentucky, was associated with a 7-fold increase in physician radiation dose compared with a patient BMI less than 25. And it was especially bad for PCI procedures. Here, a patient BMI of over 40 was associated with a, sit down for this, 23-fold increase in physician radiation dose compared with a normal-sized patient. And finally, in a log transform model, they showed that radiation dose goes up about 5.2% per unit increase in BMI. So my comments on that is this is sobering data, especially with the rising obesity epidemic. Remember that radiation exposure has both deterministic effects and stochastic effects. Deterministic effects are causal, and they require a threshold level of effect, say skin erythema at 2 to 5 grays and skin damage at 20 to 40 grays. This radiation also has stochastic effects which occur by chance. Cancer from radiation exposure, for instance, has no threshold amount of exposure, but the probability of getting cancer from radiation increases with cumulative dose. Now, though, I did find some pushback on this concept of the linear quadratic no threshold theory, in that some people are proposing perhaps an adaptive dose-response relationship where low doses of radiation are protective and high doses are detrimental. I'm actually hoping for that theory to come to fruition. Now, as for interventional cardiology, there's rightly great excitement over the radial approach to cardiac cath, but there's little talk about the added exposure with this technique. I see my interventional partners getting slammed with X-ray during radial-based procedures, especially the CTO procedures. In EP, the revolution in three-dimensional mapping has certainly helped a lot, but not for cardiac devices. I mean, cardiac devices, you're standing right there. His bundle pacing, for instance, and its learning curve has upped the amount of radiation exposure over a normal pacemaker. So I agree with the authors on radiation safety measures. I use the rad pad. Other shielding is important. And of course, encouraging the hospitals to buy more efficient systems that use less radiation. All these things make good sense. So I've decided to accept the stochastic risk of cancer from this job because it's been so meaningful and fun over the years. But this is surely an increasing occupational risk that other physicians may feel differently about. Final topic today is about hormone replacement therapy and VTE risk. Again, this is something that I didn't really know when I learned. So I work in a hospital that has an active pulmonary embolism program. My interventional colleagues do lots of clot extraction. My common question when I walk in the control room and look at this is, hey, why? Why did this patient have a PE? And HRT comes up often. So a large nested case control study published in BMJ addresses the association between the risk of VTE, venous thromboembolism, and different types of HRT used for relief of menopausal symptoms. These were researchers from Nottingham, UK, and they used data from 2 British databases to identify about 5,800 women who had VTE versus 21,000 controls, and all were exposed to HRT. The age of the women were 40 to 79. And exposure to HRT was categorized as recent, past, or no exposure. And of the women exposed to HRT, 85% of cases and 78% of controls had taken oral preparations, while 14% of cases and 19% of controls had used transdermal only HRT. So the main findings was that oral HRT was associated with an increased risk of VTE. The odds ratio was 1.58. Estradiol was less risk than the conjugated equine estrogen. In fact, equine estrogen plus progesterone had the highest VTE risk, odds ratio of 2.10. Transdermal HRT was not associated with the risk of VTE and the odds ratio of 0.93. And the absolute risk of VTE was low, with a number needed to harm of 1,000 and about 9 to 18 extra cases per 10,000 women. So I went back and I looked at other studies and found consistent data showing that non-oral forms of HRT is consistently associated with lower risk of VTE. And other authors have thought perhaps this is due to the fact that non-oral HRT avoids first-pass metabolism in the liver. So I'm looking at this data, and I'm certainly no expert, but I wonder why oral HRT is still used over transdermal HRT. And the research team points out that there's also a need to investigate different HRT preparations for a, quote, complementary detailed study of cancer risks, in particular breast cancer, to give a more complete picture, and that they're preparing such a study based on these same data sources, and certainly that's important data as well. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. Remember, if you like this podcast, please consider subscribing, giving us a good rating so that others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.